This session. This is a new session for us, but it really comes out of a lot of parent surveying and a topic that's really important. And it's interesting too, because when we kind of started the organization, certainly our kids were young, 4 years old, and now my son with JM, he's 18, in remission in UC Santa Cruz. So, but definitely through even just him going off to college, even though he is in remission, there's lots of concerns about how he's going to manage his health going forward and take ownership of that. So we're very lucky today. We have Dr. Ankur Kamdar here today, and I had the good pleasure of sitting next to him on the bus for dinner the other night. He's a great guy. He's currently the assistant professor in general pediatrics at UT Health McGovern Medical School. He graduated from Baylor in medicine and underwent a general pediatric training at Texas Children's Hospital. Dr. Kamdar completed his fellowship training in pediatric rheumatology in 2008 and subsequently joined the faculty at UT Health in 2009 as the first pediatric rheumatologist. In addition, he also has a joint appointment in internal medicine with the Division of Rheumatology, playing a vital role in teaching adult rheumatology fellows. In addition, he is also a clinical assistant professor at UTMB Medical School Galveston, and also the first pediatric rheumatologist at that institution as well. And he's kind of he's a one-man show in some of these places, so he has to wear many hats. So with that, I'd like to introduce Dr. Kamdar.
Thank you, guys. Thank you for the nice introduction, Tom. Again, I'm a pediatric rheumatologist. My main job is to take care of kids and young, almost adults in rheumatology. I do have an interest in the aspect of the talk I'm going to give today, which is transition medicine, and which is why I think the organizers thought of me. I don't do research. What I'm going to try today is highlight some of the research into the issues behind transition, talk about some of the barriers. You'll see my goals and objectives slide today. And then, you know, this is pretty informal. If you guys have any questions or concerns, I built this presentation mostly for doctors. So if there's something that wasn't clear, please, you know, stop me that wasn't clear, and then we can keep going forward. All right, so I have no financial disclosures. And goals and objectives today, we're going to go over just a couple slides on the differences between adult and pediatric inflammatory myositis outcomes, why that's important, concepts of adolescence, why this is a problem, as you might imagine. We're going to talk about facets of transition, talk about the barriers, the challenges, the data underlying it, understand the challenges of research. If we understood what the problem per se is, perhaps we can design interventions to see what works and what doesn't, and why that's important. And then, of course, from a family perspective, explore the practical resources for the clinic setting. Just to get a sense, who are the health professionals in this room, and who are the families, or somebody both, for myositis? Families? All families. Okay, great, awesome, thank you. Okay, so, you know, you guys have been learning quite a bit about juvenile myositis. I'm not going to spend too much time on it. You've seen these pictures before. You can see, do we have a laser pointer or something like that? Okay, does this oh, my arrow doesn't work. Okay, so you see the eyes, you can see the classical heliotropic rash. On the right, you can see Gottron's papules. The right hand, the bottom right, left is the MRI, looking at the muscle edema. And then on the bottom right is what we call Gowers. When a child is pretty weak, what they'll do is when they get up, they'll use their hands, and many of you have probably seen this already, kind of like a dogward, that yoga position I can't think of at the moment, but down, yeah, down, thank you. And that's how, when they're weak, this is how they get up. It's called a Gowers. It's a medical word that we use. Some of the features that you may or may not be familiar with, I'm going to go skip down to the middle picture, which is the telangiectasias, when we look at the nail folds, when we use the ophthalmoscope or the magnifying glass to look at the nail feds to see if there's any vasculitis, inflammation of the blood vessels there. The middle right is the calcinosis. The bottom left is the ulcerative, cutaneous ulceration, the skin ulcerations you might be able to see. And the bottom right is lipodystrophy. So just to highlight some of the differences between adult and pediatric dermatomyositis, the reason this is important is because I can foresee a potential problem when a physician may not know the differences, and then as a result wouldn't be able to manage the patient appropriately. In our example, it would be the calcinosis, which is much more common in pediatrics than compared to adults. In pediatrics, we see it up to about 30% of the time, and I think this is losing this. Yeah, it's going in and out. Is the mic going in and out? No? Okay. And then so calcinosis is much more common in pediatrics, as well as the lipodystrophy, compared to adults, where they're much more concerned about interstitial lung disease, which is the inflammation of the lung, and even malignancy, cancer, and death. So this is a significant problem, and we've seen this globally. I didn't put all the specific data, but you can see when we look at other countries and when they look at long-term outcomes, they are seeing the same things. Adolescents continue to have active disease by the time they transition over to adult medicine. And so it would be important for the pediatric rheumatologist to call up the adult rheumatologist, or at least educate our colleagues that this is an important thing. I would look for calcinosis, lipodystrophy. I would be less concerned about ILD in general. Of course, you may have learned about autoantibodies and which one's associated with which, but for the most part, this holds up in generally true. So in terms of transition data, what are we seeing today? The real good news is, in fact, people live longer. Back in the 70s and 80s, when we didn't really have good medical care, good treatment, many of the patients died, and this is across the board for those with chronic disease. I wasn't around back in the 70s and 80s and taking care of these children, but my colleagues do remember many of these patients having significant problems and potentially even dying because of the lack of treatments. But now, they're all surviving and thriving. The problem is that we weren't prepared to transition them over to adult medicine. We're seeing 18 million kids that are turning into adolescents and then subsequently need adolescent care. About a quarter of them have chronic needs, and that includes many people with rheumatic disease. The Institute of Medicine, which is a very influential governing body that issues reports intermittently, reported in 2014 that this is a high priority for medicine, especially in general pediatrics. And they quoted another study that ages 18 to 25 have poor health access compared to 12 to 17 and age ranges of 26 to 34. So this is a high priority for them. So I'm going to move on to the definition. What does it mean? We make a distinction between transition and transfer. Transfer is the process of moving the patient from the pediatric side to the adult side. It's more of the definitive process. Did they get to the adult, in our case, the adult rheumatologist? Transition's really more of a process. It describes an active process that starts very young, particularly in the adolescence age, and moves forward in time to attend to the medical, psychosocial, and educational vocational needs of the adolescents as they move from a pediatric center to the adolescent center. So it's a very unique distinction. So from here on out, I'll be talking about transition as an active process as opposed to the transfer, which is literally the movement from one clinic to another. So in 2002, our multiple academies, societies had issued a policy statement and developed a framework of what we need to consider when we're transitioning the young patient, and it's particularly establishing a healthcare provider. A lot of these things sound obvious, but and I think we all agree that they're important, but they're actually not easy to implement. And I'll talk about that in a few other slides. Develop core competencies. Core competencies are a pretty prominent language in our field. What it basically means is that develop measures to educate others on, in this case, transition. When we evaluate our residents in general pediatric training, we are using core competencies. Any physician in training have core competencies. They need to learn their generalist care. They need to learn their cardiology. They need to learn their nephrology. That's all. Those are core competencies. And so developing core competencies for transition is found to be a high priority because it's a particularly unique aspect of medicine. Portable medical record. That's that in 2002. This was a significant problem. I would argue it's still a problem, although it's becoming a little bit easier with electronic medical records. Although the portability is not as facile as you would like to think. If you go from one institution to another, it is possible that that may not happen. Some institutions have a certain link so that you're able to look at those records. So that makes it easier, but you can't always guarantee whoever you go to see has that ability to do so. Yes, question? That's a good question. So the question was, does privacy laws change when they're 18? Absolutely. It's state by state dependent between the ages of 12 to 18. My institution does not allow a patient to access their record, a parent to access the 12 to 18-year-old record. And that's again, institution and state dependent. By the time they're 18, the patient is allowed to access their own care. And in fact, other people cannot as part of federal law. And you can see how that's I actually mentioned that in a few slides before or later on why that could be an issue. Develop explicit transition plans. What's the expectation? And not necessarily right before you leave, but really years before, what's the expectation for an adolescent patient and then a young adult? Having the same care standards for those with chronic needs and, compared to their peers, and then having affordable, continuous health care. Again, sounds obvious, not easy to implement, and in fact has fraught with issues. And in the paper, they mentioned that this was a goal to achieve by 2010, and you can see, and I'll show you that we're not there at all, and we missed that. Particularly because it's actually not easy to do a lot of these things. So I'm going to move forward to adolescent development and why you can see some of the barriers and challenges to transition. Adolescent development is actually a very unique phase of growth. Most pediatricians are aware and get trained in adolescence medicine. It's part of their requirements for becoming a general pediatrician when we do a full 1 month to 6 weeks of just dedicated adolescent medicine. However, you may not see that in other residencies. So although pediatricians may be acutely aware, it's possible that other physicians may not be aware of the uniqueness of adolescence. It's a rapid phase of growth where there's a fair amount of biological, sociological, and social change at a rapid pace. This is where they're learning to engage in adult relationships, and you can see how this can transform in the clinic setting. They have to talk to the adult doctor. Carry out responsible roles in society. Again, being able to take care of themselves in a efficient and responsible manner, taking their medications, calling in their own refills. Again, responsibility is being established at this point. The capacity for abstract reasoning happens a little bit later in adolescence, actually much later. And this is where they learn to gain independence. So as a result, neurocognitive development doesn't actually happen until their second decade. So what you have is what's called neurocognitive dissonance, and that's a fancy word of saying your ability, your centers for impulsivity and reward, short-term reward, develops much faster than your logical reasoning, your ability to be responsible, really. And I'll show you in the next slide a nice picture about that. On the left, you can see a basic picture of a brain. The left-hand side is basically the front. What we call is a prefrontal cortex. This is where your logical thinking happens, your reasoning, your ability to make good decisions. On the right, you can see this is an MRI. Again, you can see the front up at the top, and then the back. And the way a brain develops. It develops from back to front. If you move from left to right, left is a 5-year-old brain. You can see the developed brain is in the back. That's where your eyes are located, and that's why you see. And then go forward to the right. By the 20-year-old, this is where your prefrontal cortex develops. And so now you can see why they make, adolescents might make risky behaviors as a priority compared to logical reasoning. You know, I like that slide a lot, actually. I had a slide in here a long time ago, and I can't find the slide anymore, but I have a slide from the car insurance ad. It was there's a reason why car insurances don't rent under 25 years of age, and this is really it. So I always make a sort of what hits home to most medical professionals is that why does the car industry know more than we do about adolescent medicine? And you can see why, you know, hey, it's biological. Okay, so there's barriers to transition, and many of you guys can think of the same reasonings and I can think of too. There's medical complexity. There's differences between adult disease and pediatric disease. The main example I often give is those who are born with a heart condition, congenital heart disease, when they're born, those pediatric cardiologists take care of them. But when they go to adult medicine cardiologists don't have that training to understand a heart of a newborn and the growth and development. And so as a result, it's a significant struggle. And then I gave you a couple of examples in our situation with myositis, when you might have the calcinosis or you might have lipodystrophy, and they see, adult rheumatologists will see fewer and fewer of those too. So it's an educational thing that we struggle with. Adherence. I'm sure many of you guys understand this very well about how difficult it is for a patient to take medications. I'm no different. I see this in my clinic all the time. Moving on to further research, it would be important to figure out why is it the case, and can we develop further interventions so that adherence might be better as opposed to the woeful data that we currently see today. The number of medications is clearly linked to barriers to transition. If you take more, it's very hard to be able to get a patient over and then transition them smoothly. In some diseases, you might have neurocognitive functioning problems. Not necessarily in myositis, but I can certainly see that could be an issue. Special healthcare needs, depending on if you require physical infrastructure or resources that may not be suitable for the adult world. And then, of course, sexual reproductive issues. And I talk about this quite a bit. Although me being a pediatrician, are cognizant of these issues, I would tell you that many pediatricians are less comfortable discussing these concerns compared to an adult physician. They're much more apt and able to discuss many of these concerns that I think we don't do a very good, we as pediatricians don't do a very good job of doing. Financial, family, very acute issue currently in our state right now. We're not sure what's going to happen with the ACA, but you know, I made this slide 10 years ago, and it's the same situation. Many people lose their insurance. Many people are tied to their parents' insurance. It's a employer-based insurance society compared to other countries, and so this is a significant aspect. If they don't have insurance, they can't see a doctor. So I'd like to move on to some of the barriers that have been identified by at least the professionals. I took this slide from one of a big group in the UK. The UK has actually done quite a bit of research into transition and transitional care, and they're much more forward-thinking, but although they even struggle with transition care. They've identified, one of the barriers they've identified is really the, kind of I highlighted this before, the cultural and educational divide. We as a society really call 18 and above an adult, and then under that pediatric patient, and we all understand that, again, I just showed you some pictures of a 20-year-old brain. It's not fully matured. We know already data shows that our brain is still developing after up until 25, 26, 27 years of age. So this is a significant problem. 18 is the usual cutoff for most doctors. And as a result, you can see the big issues here. On the left hand, if you look at the table, the left-hand side, the pediatric healthcare versus adult healthcare, I'm going to go down the column. Patient management. Pediatrics tends to be a little bit more multidisciplinary. What that means is that I'm able to contact my physicians, my GI doctors, my pediatricians, my cardiologist, and make a plan together. And then just giving you an example about what that means. Many of us have social worker access. We have physical therapists accessible at a very ease of manner. In the adult world, it's a lot more fragmented. There's many of those resources available, but they may not be attached to the physician that you go see. So it becomes more of a patient-centered approach, where there's a lot more responsibility and burden on the patient to coordinate their own care. Moving down, care approach, again, sorry, I went through that. Clinic appointment duration, we have a lot more time to spend with the patients because we understand we're talking to two very individual people. We're talking to the parents and we're talking to the pediatric patient. Both require help and reasoning to discuss the medical management. That takes time. In the adult world, it's really just the patient. And so as a result, there's less time to discuss a lot of concerns. And you can see where there's a problem with that too, but a lot of people would think that was inferior care compared to their previous situation. And unfortunately, it's just not the case. There's just not enough rheumatologists actually to take care of a lot of patients. And many of them will squeeze in about 30 patients per day. Just as an example, I see about 7 or 8 in one day. So they see a lot more patients, and so that means you have a lot less time, and then your concerns need to be coming up a lot faster. Follow-up, we regularly follow up people. If people miss their appointments, my nurses know to call them. They'll know, particularly the ones that have much more medical problems, and if they miss their appointments, without me telling my nurses or MAs, they'll automatically call them and say, hey, we noticed that you missed their appointment. We can get you in sooner, later, something like that. In the adult clinics, I don't think that happens as frequently. Probably doesn't, is my guess. I kind of want to go backwards, actually. Tom highlighted this a bit. I have a unique situation. I have a joint appointment with adult rheumatology, and so what that means is I train a lot of their adult rheumatology fellows. So I have a fair sense of how the clinic works, what is required to get an appointment, how their fellows are trained. I'm with them on a daily basis. And so as a result, it's easier for me to quote-unquote transfer somebody. I would argue my transition is not as easy as I'd like it to be, but the transfer is a lot easier. But I know how a lot of the physicians in the community also work their practice. And so I don't think I'm too far off by saying a lot of these situations happen in real life. There's a number of studies showing significant problems with the transition, barriers of transition. There's a lack of self-independence. There's a lack of knowledge, both on the pediatric side, the adult medicine side, and the patient as well. Lack of follow-up of the provider. It's a big problem. Many patients, there's been many studies showing this over and over, that 50% of those that are transferred over don't actually make an appointment, if you kind of find out if that actually happens. And then the lack of help. Who do you go see when this is a problem? You're kind of stuck. Here's a survey amongst pediatric rheumatology physicians looking at the barriers transition. I highlighted the top 3 ones. I remember doing this survey. It's a group of people very interested in transition medicine in the adult rheumatology world. You can see top number 1 problem, major barrier, lack of sufficient time. Even though we have 30-minute appointments for everybody, sometimes we spend way too much time on the medical side. Hey, we got to reduce your dose of this. We got to do this. We got to do that. We got to take care of your medical side. But we're not spending as much time with the transition aspect of it too, because it just takes up so much time. It's a lot of talking and discussing between both parents and the patient as well. And fragmentation, I think I put that number 1 in my survey questionnaire. The fragmentation, I think it's a significant problem that has no easy fix at all. And what I mean by that is, again, when you go to an adult rheumatologist, you might prefer the one that's 10 minutes away from you, free parking. I get it. I'm in a major medical center. It costs $15 a park. It takes about 30 minutes just to get, once you're in the medical center, just to get into my clinic. So that's a big problem with a lot of people, especially when you have a rheumatologist 10 minutes away. So the minute they turn 18, they go to an adult, their closest adult doctor, but they might not be attached to a major medical center, so they have to find their own GI doctor. They have to find their own neurologist. They have to find their own, fill-in-the-blank doctor, because it's a lot more fragmented in the adult world. And of course, we have to acknowledge that you guys, children, were diagnosed with the same doctor, and you've kept them for 6, 7, 8, 9 years. You've developed a strong bond. And then now you're going to see a new doctor. You don't have it. And there's a major issue. Not only do you not have that bond with that doctor, but they are not going to develop with you. They're going to try to develop with the patient. And so parents feel like they might be being cut out, when it's really not the case, but that's the way adult physicians will think. This is a patient-centered medicine. We have to advocate for our patient. We're not, and it's a privacy issue too, as you mentioned before. These are patient side. This is patient's quotes, specifically taken from one study. Again, this is done from the UK, looking at patient attitudes when they transition. I like the first one. First one hits home for me quite a bit. Again, a lot of things we don't think about too much until it happens. This patient couldn't find a room in the pediatric ward or the adult ward, so they found it in a geriatric ward. That's a big problem, and you can see how that can happen. I can actually see how that happens. In my hospital, I have a struggle admitting an 18-year-old. It takes a talk with an administrator, and then I have the wrath of my nurses, I have the wrath of my administrators. It's not an easy solution. And not only that, and I'll show you some data a little bit later, but many of my colleagues are not comfortable taking care of 18 and 19 years old too, my pediatric colleagues. So I'm on an island. So as a result, I have a policy now, because it's just too hard to actually accomplish these goals. Many of these patients get admitted to the adult side. My adult colleagues will take care of them, and then I'll see them back in clinic if they haven't been transitioned yet. You know, I talk a lot about the problems with the adolescent brain. They're not developed, and so they make poor decisions, and then they're not taking their medicines, and we're talking about self-management. They can't do it. But I've always had the hypothesis that I would argue adults are not as good either. I can't take a medicine daily for 2 weeks. I can already tell you that. So imagine myself as an 18-year-old trying to take a medicine daily. It's not easy. It's extremely challenging. and I think we can acknowledge it. I actually found this study. Dr. Fishman's a doctor who's a GI doctor who takes care of IBD, which is a diagnosis of autoimmune disease that affects the intestines. And they looked at patients that are adults, and turns out that they're not as good either. So their conclusion was that, well, maybe our expectations are too high. Oh, yes. So the question is, are there any apps? Actually, I learned quite a bit from you. I wasn't aware of one, but if you have something to suggest, Medical Alert?
Thank you. Yeah, for my pain meds, Medical Alert's got a reminder thing on it. I have blister packs, okay? I don't take my meds on a regular basis, and I have reminders set on my phone to take them, so.
Yeah.
Yeah, exactly. Like, I know, and they're in blister packs, so they're easy, but it still doesn't always help.
You actually mentioned something that I have to make a point of in a later slide in terms of apps and technology, and making things more relevant for some of our younger patients is important too.
As a teenager,
yeah.
I had the app and I deleted the app because I got annoyed of it.
Which one? Which app?
Any app. I've had multiple ones, but I've deleted all of them because I
Oh.
just got tired of them. Yeah, like, because, like, you know, you don't take your pills at the same time every day. I take them before I leave the house. And so next thing you know, I'll be at school and I get the medical reminder. I'm like, too late. I already left, so I just deleted them all. There's no point.
Well, I appreciate that comment. So it's important. Maybe, you know, we would think apps are a great idea, but you heard it from somebody that actually does it. It didn't work that well. There's too many reminders. Sure. That's important. Yes? Yes. So the question is, are the medicines the same for adults and pediatrics? Yes. For the most part, if you're referring to inflammatory myositis, absolutely. The doses might be different, particularly because we dose based on milligrams per kilogram of a patient. So if they're a very small patient, we'll dose by their weight. It's very standard practice in pediatrics, and in adults, it's a standard one dose. Not quite true for a lot of the medicines, but it's pretty standard of care for adults to dose a standard dose. I can't think of one medicine, at least for myositis, that would be significantly different that pediatrics or adults don't give or do give. Oh, sorry. So going back to the last slide, just to highlight, so what's happening now? So what a lot of institutions are doing is developing a program, and that's sort of loosely defined as basically some way of being able to transition a patient to the adult side in a systematic manner. And I've listed some of the ways people have tried to do that. Individualized transition plans. So if you come to my clinic, I've written out a plan for you. This is what I like you to do at this age. I'd like you to do fill in your medicines, call in your own refills, make your appointments by this age, and so forth. Utilization of a coordinator, somebody designated in the clinic to say, you are the person to help this patient being transitioned over to adult medicine. Adult practitioner seeing patients in pediatric clinic. Again, so in this setting, it'd probably be some adult doctor who is comfortable seeing patients at a younger age and perhaps going back and forth, them seeing once, or and then the pediatric doctor filling in, or just kind of having an appointment with them and then having an appointment with me, having an appointment with them until they're officially transitioned over. That's kind of loosely defined, but the idea is that somebody's engaged in their life before they actually transfer. An establishment of a quote-unquote transition clinic, designed to transition patients over. There tend to be more adolescent patients, of course, and then again, depending on their age, trying to teach them how to improve the transition process. So we've seen good effects from that. That's shown in multiple studies, but the problem is, you can imagine, having a transition clinic, you have to have a fair amount of resources. They're pretty costly. As an example, for me, I'm by myself. I don't have a coordinator. I'm the coordinator. I have adult rheumatology doctors with me, but they're also busy seeing patients too. So I could potentially have them see and meet and greet. I don't have a lot of resources built in to develop a transition clinic. So you can see it requires a large major medical center with a lot of resources. So the challenges in transition research, I'm not going to try to bore you too much with research, but there's a fair amount of problems in trying to understand what the actual problem is and how to fix it. A lot of the studies have centered on need. We need to get patients better to adhere to their medicines. We need to get them to the doctor. We need to do this. We need to do that. That's what the research is showing, as opposed to developing an intervention. Hey, I've done this and this works. I've modified my clinic and this works. You're seeing it a little bit more now, but it's still in its infancy. What I mean by multidimensional and domain aspect of transition is we are so focused on the medical care. I'm trying to get the patient better. I'm trying to get them stronger. I'm trying to get rid of the rash. This is what I'm doing. But I forget that they're missing school. They may not be able to graduate on time. They may not go into college. And this is important. They need to get an education. They need to have vocational skills. I need to get them a job. I need to help them get a job. Because if they don't have a job, they don't have insurance, and then they don't go to a doctor. So we become a lot more cognizant that it's just not the medical aspect we have to worry about. It's the other stuff that's important too. This design of intervention, this goes back to our patient that discussed the apps. I was going to mention that we need to make it more resonant to a young patient. You know, when you think about a study, you think about a randomized controlled trial. Well, what does that entail? The patient has to come to clinic. They have to spend 30 to 45 to maybe an hour sitting there doing a survey, getting a medicine. And that takes time. It takes money because it's on their time and their parking and their schedule. So maybe there's an app that's available to fill out a survey to understand how they're thinking. Or maybe there's a telemedicine that we need to establish to sort of develop that, to understand, again, to research and obtain data. The great pediatric and adult divide, I'm not going to spend too much time on that, but basically that means that if a patient is in a study when they're 18 or 17 or 16 years old, it's not ideal to get them out of the study to just move over to an adult doctor. One, that research is invalidated if that patient ends up leaving the study. And we already have a problem enrolling adolescents in studies. They tend not to enroll in studies for a lot of different reasons. But if they're not enrolling in studies, then we don't have a good opportunity to understand them. And when I talk about studies, it doesn't necessarily have to be a therapeutic trial. We're trying a new medicine X. I don't want to make you feel like a guinea pig. These are more, a lot of them could be surveys. A lot of them could be, hey, we want you to take prednisone at this dose as opposed to that dose and see if at a shorter, longer time period, is that better or worse, that sort of stuff. It's important to include adolescents. We don't want to exclude them from studies. That would be a disservice to them. But we also don't want to coerce them either. And that goes to the participation in research and understanding consent and privacy. So what do we do? I'm with the hopeful solutions, at least to make a better transition for many of us. And I think that's why you're perhaps here. In 2011, AAP, actually multiple academies, decided to issue another report, provides guidance on how to do this. And so as a result, there's something called GOT transition, and I'll show you some screenshots of this. I think this is more of the money slides for all of us involved in transition care. How do we make this on a daily practice for patients to transition over? There's a big push to start early. And when I say early, 12 to 14 years of age. And you might think, wow, that's really early. And even I thought that was really too. But I think if you start at 16, 15 years old, you're really behind the curve. And it's really age appropriate. And what I mean by that is if you start at 12, 13, then it's really more of a requirement of, hey, knowing your medication names, just as simple as that. and then building up to improve self-management skills, adherence skills, and so forth. So by age 14, maybe they've already known the names, and then they're talking about the doses now. Hey, I take 10 milligrams of prednisone. If I told you how to get to 5, is that a reasonable solution? And there's more engagement with the teenager in these conversations. And so now they're hearing about the dose as well as the name of the medicines. As many as you know, we don't know the colors of a lot of the medicines, and many people will say, it's the white one, it's the pink one, and unfortunately, they have multiple colors for multiple medications. It just depends on where you got it and the brand name and so forth. And so I know the dose, I know the name, and that's how we engage in discussion. And that's important. So here's a screenshot of Got Transition. This is actually a very good tool, internet-based tool that I use quite extensively. I'm not successful in it, but I use it quite a bit for a lot of my patients. At the kind of the top-ish, you can see the brown section is called Healthcare Providers. Right next to it, it's called Youth and Family. So it's very pediatric and patient-centered, and understanding how to do this. I personally would use the healthcare providers, and it's a step-by-step wise approach. Some things are easy and some things are not, and that's why it's pretty nice because it's flexible. I care more about somebody that has significant medical complexity, so I might go through all 6 steps. You can see on the left-hand side the kind of pop-out box. It says Introduction, and then the 6 steps about how to transition someone over successfully. And I might pay attention, less attention to that, to those patients in remission that don't necessarily need to have all the steps. And you can see at the bottom, there is a recommended healthcare transition timelines. Again, they're emphasizing the age 12. Not everybody's going to be ready at age 12. I certainly don't want to meet somebody who's a new diagnosis and start talking about transition. But it has to be part of your daily routine, just like a physical exam. And hopefully I can get there at one point. I'm probably starting at 13, 14 at the earliest. And then you can see they also recommend that the transfer really should occur between 18 to 21. And because I know a fair number of pediatric rheumatologists will see patients well above 22 years old. Unless you're medicine pediatrics, which is the training where you get medicine and pediatric training, it's a 4-year program, I would argue that it's probably a reasonable suggestion to transition over patients by that time they're 21 years old. And when you click on the 6 steps, you can see on the left, it would apply to me. This is the healthcare provider part, where it says transitioning youth to adult care providers, transition policy, transition tracking and monitoring, transition readiness. I have a few slides about what that means, transition readiness. Are you ready to transfer? And the next 3 steps, planning, transfer, going back to that word transfer, and then transfer completion. So the process actually doesn't stop once you've done it. It's important to get that feedback. I think that's something that we lack quite a bit. I'm lucky enough because I transfer over to my adult colleagues quite a bit, and I hear back from them because if I don't, I'll call them. But I think it's a big problem that many of us have nationally. Going back to transition readiness, there's a survey that sometimes, I'm not as good as I'd like to be in terms of using this, but this is I'll show you the sample questionnaire, but this is an easy questionnaire. Parents and pediatric patients can take this and to assess their readiness. And it asks lots of different questions. Some are a little bit easier in terms of accomplishment, and some of them are a lot harder. And here's a sample questionnaire. At the top, you can see, do you fill your own prescriptions if you need to? And on the left, no, I don't. No, how? And then all the way to the right, yes, I always do this when I need to. And there's many questions regarding appointments, tracking health issues, talking to providers, all important things in the transition period. And there's condition-specific tools as well for me. They don't have one for inflammatory myositis, but they do have one for juvenile arthritis and lupus. hopefully the Myositis Foundation will be developing a very condition-specific tool soon, but I have not seen it yet. This is as of 2 weeks ago. And here's a sample of the juvenile idiopathic arthritis condition-specific tool. Those are all from the Got Transition website. You can find it there. It's a very nice, easy, understandable website. So here's my recommendations in regards to typical things I talk about. Develop an appropriate age plan for independence and self-engagement with doctors. This is where it's important to really start talking about what you are concerned about. Usually it ends up being the parent. I really need the patient to engage. That's easier said than done, particularly for the quiet ones, because I never get to hear their concerns. Encourage solo time. What that means is that at a certain age, the physician should be requesting solo time, 5–10 minutes of complete private discussion that does not include the parent. And if I have to sit there for 5 minutes without talking, I will. And just to be there and just to say, I am here, I'm not going to put a lot of stuff, I'm not going to discuss any of this with your parents or mother. Here's my email. You can always email me as long as it's not an emergency of some sort, and to discuss a lot of these concerns. Practice a summary of medical care. This is actually really hard. I take 3 years to teach my pediatric residents how to do a summary, how to efficiently describe a patient in 2 to 3 minutes. I think this is extremely hard and difficult. They have to do it for any patient. To do this for yourself, this takes time and practice too. What I usually do is in most of my notes, I have, and most of us do this too, we have a summary of the life story of a patient, mostly medical. I have now a 13-year-old patient that originally was diagnosed at 7 years of age. They were diagnosed with dermatomyositis because of these reasons. They are on IVIG for several months and subsequently weaned off prednisone and now is doing well. If you can do that, you can gain a lot of trust from new physicians, especially the ones you don't know, because they will take you seriously. I hate to say it, but I know, again, how many adult physicians think. I interact with them on a daily basis. They're super smart, but I think they don't have that strong engagement with adolescents as much as we do. Yes? The question is, do I have a form to help adolescents do that? No. What I do is I give them my last note from the time before. If I'm in clinic, I generate a note each time I see a patient. So usually, again, I'm not very good at this on a 100% basis. We give them the note beforehand, the one I saw the last time, and then I'll hand it to them, and I'll ask them to memorize the section that I want them to memorize. And it's in medical jargon. But if you can memorize it, and if you don't understand it, I'd be happy to start going over with you to understand what that means. But if you can actually say that to new physicians, it will make you heads above everyone else, including adults. Again, it's hard sometimes, and it's not a one-liner because many patients are very complicated. But this is important. If you have to go to the ER and you're 19 years old and you told the physician, well, I have myositis, I was on some medicines, some of them might be IV, that's not helpful. Especially when they're in the ER setting, when they're trying to figure out if you are need to be admitted or not. Who do I contact? Who can I help you with? And so forth. I heard a story maybe 2-3 days ago about a mother telling me that their college-age daughter had to go to the ER, and she had no help and had to call her mother for help. And it's common. It's not like this is a unique situation. This is a regular situation. And so, like I said, a lot of these things are not easy, but if there's some work put into it, it makes you much stronger from a transition standpoint, and I'm much more pleased if you can do something like that. Portal access, again, it's always an issue. And I don't have any good advice other than trying to get the records yourself. Physicians always promise, oh, I'll send the records over, and for some reason it doesn't happen. I'm terrible at it. Other physicians are terrible at it. It's just not easy. Particularly if you were diagnosed early. There are a ton of records. It's about 1,000 pages. I don't want to see 1,000 pages. I want to see a good 5-page summary, a 4-page summary, but that's not easy. But if you had the records, that's better than nothing at all, particularly when you get to the new doctor. I would argue many adult physicians won't see a new patient until they had the records in the first place. So I usually encourage portal access. What that means is that if you can access the portal for your institution, again, my hospital policy, they don't have 12 to 18-year-olds accessing their own records, and so it becomes a major problem, as you highlighted before, about accessing the portal and looking up labs and images and x-rays and the notes. And then becoming involved in your community is kind of a plug to CureJM, but I actually believe that if you become involved and engage your network and your community, you learn a lot. Again, you're not the first person to undergo transition. Learn from people's experiences, what worked for them, what doesn't. That's probably what I've learned the most about transition is when the patient either transitions over or for some reason has to go over to the adult doctor, and then I get the feedback. Hey, this really worked, that did not work. And then I'll tailor my practice depending on what I hear. Most recently, actually, I'll go to the next slide. I'm going to go to the bottom, college resources. It never occurred to me, I usually tell people know where the student health center is. I would argue now, after talking to a caseworker at the student health center, they are much more knowledgeable about resources in their community than I am. And so as a result, I've started advocating that if you're going to a university, particularly four-year universities, two things that you need to do. You need to go to the student health center. You need to perhaps talk to the caseworker or social worker and say, here am I. You give your 3-word summary. I need some help doing these things. It's kind of hard to do, to advocate and say, I need help, but it's probably in your best interest to do so. Same thing with the ADA, American Disabilities Association. Every college that I've at least am aware of has an office for ADA. Now, nobody wants to think of themselves as disabled, and I've learned this quite a bit. When I try to even give people handicap placards because they need it, almost 75% of the time they refuse. And so I do get the sentiment that nobody wants to think of themselves as disabled. But again, it's catching the people that understand the law, the resources available to them, and what can make their lives better for them so that they can transition smoothly. For example, the caseworker particularly, I had a patient that lost funding. I didn't know what to do. They're in a 4-year college somewhere else, not in Houston. So I called the student health center. I was asking for the doctor because maybe they knew, and they referred me to the caseworker, the social worker, who knew a lot more, which makes sense. I just never even thought about that they might have these resources. The title of that slide is Personal Thoughts and Biases. You're not going to find this anywhere in sort of textbooks or recommendations. These are things that I've sort of learned over the past 7 to 8 years. And not one plan works for everybody. And I'm not very successful a lot of times in many patients, and it's always been a struggle for me, despite me attempting to actually do a lot of the recommendations. I don't have a transition program. What I have is the adult doctor right next to me. I also have the phone numbers of probably 20 adult rheumatologists across the state because I know them personally. So if they go to Austin, A&M, Dallas, Texas Tech, Corpus Christi, San Antonio, I know doctors that I know can at least take care of a patient, because if they don't know, they can call me. But that's unique to me. Yes. Yeah. Yeah. So we got the mic here.
Oh, so the question is, do you want to funnel your patients towards private or academic? I'm sure a lot of it, an academic situation or setting, a university hospital, it probably depends on their health insurance as well. What's your preferred, or what's your spiel about it?
So I'll give you my spiel, and again, I'll give you my personal bias. This is what I tell everybody in clinic. At 18 years of age, you have the choice of going to who you want to see. And that's a basic fact of life. So if you want to go see the guy or the lady, many female physicians out there, who is 10 minutes away with free parking, and I'm tired of the business of coming to the med center, it is your choice. Sometimes I'm comfortable with that, and sometimes I'm not. And then with your health status, I am or am not about. And because here's the reasons why. You haven't, and for example, for the ones that are that I don't feel are transition ready, I would say you can't do a lot of the things that we just talked about. You can't describe your own symptoms. You look to your parent, and these are not marks against you, but this is what I need for you to engage a physician, because if you come in here in an adult setting and not express your concerns, and not know your medicines, and not know your story, you're going to look bad, and that makes me look bad. But and I don't want to look bad. But I want to make you look good, and if you can do those things, you look really good. You look better than most people, including adult patients. And so, so in those situations, I think it depends more on medical complexity and transition readiness for me. I don't have a bias on private versus academic. I say there's risks and benefits, and which is true. The risk of going to an academic major medical center is that logistical. Again, I've talked about the med center in Houston. It's very difficult to get in. Not every doctor is in clinic every day. I am not in clinic every day. I am in clinic 4 days a week. I don't have clinic the whole day. I don't have nurses manning the phone the whole day. This is a problem. If you feel like you want to be able to get in soon, I'm not your doctor. It's just that hard. And so it is possible, I can foresee, for example, if you want to go to the expert in a certain disease, they're probably at a major medical center, and guess what? They probably are supposed to do research, and they're in clinic 1 half day a week. If that is for you, then you should go to that doctor. But you have to understand, you've got college, you've got a job, you've got a busy lifestyle. If that doctor has Monday clinics and you can't do Mondays, that's a problem, and that's academic universities. Academic universities do have clinicians that are in their clinic all day long, but it may not be the one doctor for you. And it's hard. Sometimes I do get choosy when it comes to certain patients. I feel like they can connect better with maybe a younger physician that's in clinic every day. If they want to see the expert, then we talk about that. I do tend to refer to people I know. Again, it's mostly because of the communication issue, and that's more of my personal bias. Somebody asked me, who would you go see? And I use, if they are not complex medical individuals, I would say depends on your suburb, because I know about 90% of the adult rheumatologists in Houston. But again, this is not advice you can apply to maybe your area or your physician, because they may not have those resources. Like I said, I'm in a unique position. Most pediatric rheumatologists are in a major medical center that are centered on pediatrics. The goal is pediatrics. And of course, the other corollary to that is the Pedro Policy. I don't really have a policy. I see everybody at least through high school, and then including the summer, until they go to college, and then for them it's their choice. I would be happy to see them up until they don't want to see me, but at about 20 years of age, I start becoming a lot more uncomfortable with the medical complexity for adulthood. And hospital policy, I kind of mentioned this before. What's the policy of a hospital? Do they admit above 18, under 18? Where do you go? Again, that's something I think about a lot, but I don't think we think about too much, but it's an important issue too. My bias is that if you are successful at your transition, you'll know more than your doctors do, other than your adult rheumatologist, and potentially even more than them, because again, you're knowledgeable about calcinosis, you're knowledgeable about inflammatory myositis. They take care of so many diseases. They may not be up to date with the latest and greatest as much as you are. I would say embrace that, and not try to be too mean about it. You know, it's okay to express, hey, I've noticed that in the pediatric literature, or my doctor had mentioned that this works for calcinosis. What do you think about this medicine? You think it'd be right for me, as opposed to saying, you know, or not engaging the physician. Most physicians, I think, would be acceptable to reasoning like that, but that's actually hard to say. You know, there was a session about how to talk to doctors. That's important. You don't want to look like a know-it-all Dr. Google. Although even I encourage it, you know, you don't want somebody rolling your eyes. That's not helpful for you at all from a care standpoint. But you have to just accept the fact that you will know more, particularly with non-rheumatologists. If you have to go to ER, you will know more about dermatomyositis. You will know more than they will. You know that labs don't always reflect the disease, and that's important to understand. The care is more fragmented. I think it's getting worse, in my personal opinion. And unfortunately, I don't have a good solution about that one. I'm just sort of a behind-the-scenes kind of guy, just trying to understand the landscape. Particularly if you want to see certain doctors, you may or may not be able to because of your insurance or whatever the circumstances. Maybe you're in a four-year college that is away from me. You're just hoping that perhaps somewhere, somehow, those doctors are communicating with your other doctors, and if not, then you have to do that yourself. There's a lot of burden in the adult world on you as a patient to get people to talk. Doctors are busy. They have to talk about 40 other patients, probably more ill than you, and so as a result, you lower priority. And again, I don't know the solutions for that, but that's just sort of my bias. I think it's moving in the wrong direction, in the U.S. particularly. I think we have other models that we could emulate elsewhere, but that's probably not feasible anytime soon. Yeah. I put some resources up there. In red are the ones I felt are more patient ease of understanding and from a knowledge standpoint, although these were the recommended ones that I found. Of course, I put the GOT transition. I think that's a very nice tool. You'll learn a lot from GOT transition. You'll learn about how to understand transition readiness, what it means to have a policy in place, and understand what transition means. It's a lot of the concepts I just talked about. The left-hand side is where I got a few of those things, the left-hand picture. And hopefully we can have a patient that doesn't lose their brain to somebody that knows more than I do. Any questions? Yes, sir.
Sure if you had any more questions. No. I have a question. And you said you've been doing the teaching thing for about 4 to 8 years, you said?
You're talking about transitioning, or what are you referring to?
No, I'm talking about just your education. You say you spend a lot of time with these other doctors.
Oh, yes. So I'll tell you my role. So the adult rheumatology fellows spend a half day with me every Wednesday. And so for the past 5 years, every Wednesday, I have an adult rheumatology fellow who is a doctor in training, learning their rheumatology with me, yes.
Are they younger doctors, or they're all younger?
Yes, correct. The question is that they're younger. So what happens is, so most of these physicians do 4 years of medical school, and then they do 3 years of internal medicine, where they learn their general adult medicine training, and then do 2 years of rheumatology, as opposed to what we do, pediatric rheumatology, 3 years to become board certified as an adult board. That's actually a good point. I should put that in the slide the next time iteration I do this. So they have 2 years of adult rheumatology training, and then they're eligible to become board certified adult rheumatologist.
Okay. And the reason why I question it is I've been involved with the EHR part for about 21 years. And through the markets, we have seen doctors in total control, administrators in total control, and most recently, doctors in total control again, which means that they determine what software is running in their system and what they're personally, I think they're trying to do too much. You know, I mean, look at all the great ideas you have.
Yeah.
You don't have the time to do it.
Yeah.
And I don't even think it's a doctor's role to do that. I think I walk into my physician and I got to catch him up every single time. I got to answer the same questions every single time.
Yeah.
He's phenomenal by the end of the conversation. Okay? But he doesn't do the appointments, the scheduling, the labs, all that. He reviews that stuff before I get in there. But I think that when you try and do too much, it's just you can't have a transition role if it's just the doctor.
Correct.
Right, you know.
I used to have this slide. You know, you make a good point. Unfortunately we place a lot of burden on ourselves about it, but it's really the patient, it's the community, it's us, it's the social worker, it's your team that helps you. A poor transition doesn't occur with just one person, whether it's the parent, the physician. Again, it takes a big team, and with the patient in the center. Because you're right, it just takes too much time to actually do these things. I've got maybe 30, 40 patients that are ready to transfer over, and in my mind I'm like, yikes, there's 20 of them that are just not ready. But those are the ones that probably without the resources. A lot of times when I talk about this, I'm preaching to the choir. I think a lot of you guys understand this concept. You guys are pretty helpful. You're here at a meeting to understand and learn. It's those that don't have those resources that are not here in learning and educating themselves. For whatever reason, they're just they're too busy. Maybe they got very little help, a couple jobs, trying to make it through. Those are the ones that we really need to reach, and it's a battle. We got quite a bit of time, right, for this room. I'm more than happy to stick around. Yeah. Yes.
So when you're gonna switch your doctors and you're gonna give them the papers that tell them about what medications you've been on, I've had it my whole life, so I have a lot of papers. So how would I know which papers to give them?
So the question is, how would I know which papers to give to the new doctor? I think that's a very good question. Patients like yourself, if you've had disease for a very long time, will have thousands and thousands. And as a physician, I get them already from other physicians that are transitioning over patient to me. I don't know if I think I may not mention this, but a lot of doctors know that I want to see many of these 18 and 19 and 20-year-olds, particularly in this stage of their life, because I'm more fearful of what's going to happen. So I end up seeing them a lot because I want them, and I don't want a stack of papers. So what I personally do is I usually make a summary of every patient embedded in my note. So usually all you need from me is the last note, because it'll have that good summary. And that's what I tell my patients to basically memorize or learn. And sometimes I actually make them practice it too, because if they don't start with the right sentence, then again, you're starting off on the wrong foot. I'll give you a very stark example that doesn't apply to most of us here, but I had a 16-year-old present with a heart attack and eventually had a diagnosis. So when we practiced the statement and the summary, they started off by saying how they were diagnosed. Well, I felt weak and I was ill and I went to a lot of doctors. I stopped them right there and I said, you start off by saying, I initially presented with a heart attack. And that will get people's attention because young people don't have heart attacks. I hate to say it, but you have to get the doctor's attention. And if you're able to do that without stumbling and then describe basically what happened to you over the past 7 years, you're so far ahead of the curve compared to everybody else. So for example, for the typical patient with dermatomyositis, I would say something like, I was diagnosed at 4 years of age. I had a muscle biopsy and MRI. I was on IVIG for multiple months from the years 2005 to 2007. I did not have calcinosis. That's actually a kind of important thing to put in. What do you not have? And I've been seeing my doctor for every 3 months, and now I'm ready to see my new doctor. Again, 4 or 5 lines, and it gets you so much farther that that physician knows that you mean business, that they'll take you seriously, even though if it's a difficult symptom. A lot of times we have difficult symptoms of I feel weak, I feel headache. It could be a lot of different things, but at least they'll take you seriously and then want to be able to take care of you as best as they can. My feeling is that if you start off with saying, I had some IV medicines, I don't remember a lot of things. And you may not remember. That's okay. I don't care if you don't remember or not, but at least you can say what happened to you. But if you say, I don't remember if I had an MRI and a biopsy and I had all these labs, it doesn't help, because then you're put into a category of you don't know that much. I'm painting my adult rheumatologist in a bad light. I don't want to. I would argue that pediatricians are just as bad in a lot of things, but I'm being a little bit more generous to myself. I think if you really pin me down to it, I think pediatricians are very bad at talking a lot of the concerns that adult doctors have, the gaining the self-independence, how much we rely on the parents, how much I personally engage the parent as opposed to the patient, not doing the 5 minutes of solo time. I can give you excuses, but it probably shouldn't be an excuse. It should be the standard of care. And I think we do a very bad job of that. The adult doctors accuse us, I'm going to lump us all together, of babying patients ultimately. We do everything for them. It's a cultural thing, if you will. It's that's how I've learned how to take care of patients, is babying them and holding their hand. And if they miss an appointment, when then they get one from me, they'll get a call from me. If I get I'm trying to think of examples here of how the system is not ideal, and it works both ways. So if I had an adult colleague with me, they would probably say those things, and I wouldn't take offense because it's probably true. To go back to your question, I can't speak for all my pediatric rheumatologists, but I would say for a patient with myositis, at the minimum, you should have the last 2 notes, the first note ever when you are diagnosed with myositis, biopsy report, and MRI report, and the last set of labs. Most, again, I'm generalizing doctors. Most adult rheumatologists, what the front office will say is, we need all records, and they emphasize the all. Well, you don't need all. The doctor does not want all, but the front office is telling you, because that's what they're told, that you need all. And what I would say is, this is all, and then move forward from there. The question is a clinical summary. I would argue many of it's incorrect, even including multiple times mine, because garbage in, garbage out. I'm being quite frank and honest about the concerns that I have, and you can see where this is coming from. We have a clinical summary, so every time a patient comes to the clinic, they generate a clinical summary. So that means that the medications are listed on the note, the next appointment is listed in the note, and maybe it says something about what happened that day. And there's a set of labs that maybe are put in the note also. Medications, everything is probably useful except for the medications, because I can tell you, I myself, including at least my institution colleagues, are not very good at updating that. Sometimes I'll tell patients, hey, come down on the prednisone by 5, but I forgot to change it. Because you know what, I do it later. And when I think about it, or when I generate the note, which is about a week later. And then it'll be updated, but you don't get that update, because you get it at that point service. The most helpful, in my opinion, for clinical summary is the next appointment date. Usually when a patient, so going back to the example, I tell my colleagues, I need all the 18 and 19-year-olds that you think are going to struggle. What I need from you is the last note and the first note, and then I'll go from there. Then I'll decide what I want. Hopefully there's, so the question is there medication information in that notes? And I would say sometimes yes, sometimes no. But it's better than nothing, and I don't want 1,000 pages. It's usually about 900 of them are useless. Or they say the same stuff, or it's incorrect information. I don't know who's putting it in. Our EHR, our gentleman had a concern about EHR. It's again, garbage in, garbage out. Sometimes it's just bad information, and you don't know what to trust. Epic is relatively nice from a medical record standpoint. A lot of institutions use Epic, and the nice thing about Epic has a function where you can transfer the records instantly. I don't have access to Epic, but many institutions do. It's pretty pricey, so it's catered to large institutions, large academic institutions, not mine. But if you go to a private doctor, they probably won't have Epic. Well, that's pretty much it. I'll hang out for a little bit if you guys have any personal questions, things you wanted to talk about. And then, of course, I think the Cure Jam has my information too, so if you needed to contact me. Again, I don't claim I'm somebody that does this well. I'm more aware of the literature at hand, what people do, what works from a research standpoint, and then my unique situation, I think I do it better in some ways and then poor in others. Thank you very much. Yeah. What? No, one more question. Everything's helpful. I learned quite a bit from you guys, actually. I didn't emphasize that enough. Maybe I did, but I learned so much more from people who've experienced this than anything else that the papers can teach me. Yeah. Mm-hmm. Where they can transfer, you can input all your medical records. Mm-hmm. Mm-hmm. And so I don't know if that's useful, but it might be something.
Do I need to put?
The question is, there's an app called Care App.
CareSync. CareSync
that could potentially be helpful. I think it depends on how it works. So how are you going to import all of those records into an app? Is it a image? So if there's an image report, do you take a picture of it and it gets loaded into the app? How does that work? I'll check it out. I'm more than, again, I just, like a year ago, I learned something about Good Prescription. I never heard of that until, has anybody heard Good RX? It's a neat app that, let's say you have a high deductible and you have an antibiotic that's potentially pricey, or any medicine really, Good RX. It, within your area, it'll compare costs of the medicine. My own sister had her daughter who required some antibiotic, and they have a high deductible. So instead of paying $160 for the antibiotic, it was $80 for the antibiotic a block away. Very impressive app. It could be helpful, and what it does is it tells you the price without the insurance. But if you have a high deductible, so if you have insurance but you have a $1,000 deductible, you're going to pay through cash no matter what. This would be helpful, and it saved her $80 just from a block away. It boggles my mind. How is that possible? But CareSync, I'll take a look at CareSync and what it has to offer. I'm always more than happy to engage apps if it helps my patient, and if I think it's worth looking into, then it's worth looking into. All right, guys. Thank you very much. Thank you for coming.